Hello, everyone, and welcome. I'm Zoey Martin-Lockhart, and I'm actually in anthropology. I'm a PhD candidate. I'm at the University of Illinois at Chicago, and my dissertation research focuses on the work of medical students and doctors with disabilities and their work to increase disability inclusivity in medicine. So the other people listed here are first the panelists, who are the folks also helping to organize this program. Dr. Poullos, Dr. Sutha, and Dr. Rastogi, who are all here. And then Dr. Kim and I will be helping to facilitate and moderate the panel of them. And also shout out to Dave Keen, who does a whole bunch of the other coordination stuff and is super important as sort of a glue. I will turn it over to the panel, Dr. Poullos, Dr. Sutha, and Suchi. And I'll ask you to start off by introducing yourselves briefly and speaking a little bit about what kinds of topics you feel you could best answer questions on, or what you could best speak to. And maybe you can say just a little bit about what led you to help organize and or found, depending the program.
Sure. My name is Ken Sutha. I am a pediatric nephrologist here at Stanford and co-chair of SMATI along with Dr. Poullos, and have been involved with this mentorship program from pretty early on when Dr. Poullos and Dr. Kim got together and started this. In addition to being a nephrologist, I also have kidney disease myself. I was diagnosed with kidney disease when I was about 10 years old, ultimately found to have FSGS, focal segmental glomerulosclerosis. Ultimately, doctors were able to slow the progression of my kidney disease, but not stop it completely. So by the time I was graduating from college, I knew I would need a transplant or dialysis to survive. At the end of my second year of medical school, I got a transplant, living donor transplant for my dad. And then I did an MD-PhD program, so it was a transition point between finishing up the first preclinical years and starting my PhD. Of course, transplant is great. Was able to do lots of things afterwards. Had a lot of more freedom than I would have had being on dialysis, but it comes with its own sets of challenges. Transplant's a treatment and not a cure, like many things. And I dealt with a lot of issues related to infections and rejection, kind of ping-ponging back and forth between the two, and ultimately had rejection and decline in my kidney function after about a decade after my transplant. At that point, I was transitioning from residency to fellowship, and so was on dialysis for about 2 years before receiving a second transplant now back in 2018. I've been doing pretty well since then. Again, as I mentioned, it's not always a smooth road, but it's a lot easier than it was when I was on dialysis. And around that time that I got my transplant is when Dr. Poullos founded SMATI. At that time, it was called SMAC. And I learned more about other people in the medical field that had disabilities and chronic illness. During that whole time when I was had my transplant, even when I was on dialysis, I didn't identify myself as being disabled. I started to think about it a little bit when there were discussions about going on disability leave and kind of like from that like employment standpoint, but not related to disability identity. But in learning about what Dr. Poullos was doing with SMAC and SMATI, I learned about many common experiences that many of us have trying to navigate the medical healthcare system from both the patient and the provider perspectives, and the shared experiences that we have. And through that, I've learned a lot. I continue to learn a lot about the experiences of people with other kinds of disabilities and chronic illnesses, and the collective power that we have in embracing that identity and owning that identity. And those were that I think is a lot of the reason why I wanted to get involved with this mentorship program. I felt very lonely going through the process of medical training, thinking that like I was the only one kind of going through this, but learning that there were others that had shared experiences, even if not the same exact diagnosis. I think there's a lot of power in that.
Okay, I can go next. So, hi everybody. My name is Suchita Rastogi, but you all can call me Sushi if you want. And I use she, her pronouns. For those of you who need a visual description, I have very short black hair and brown skin, and I'm wearing a mauve sweater and sunglasses. I may have to turn off my camera at certain points tonight. So in that case, you'll see a picture of me in a white coat, coat, a white coat, glasses and a ponytail. I'm a disabled clinical phase MD PhD student at Stanford, but right now I'm on an extended medical leave of absence due to my chronic illnesses. I also am a first generation American of Indian descent, so my parents were immigrants, and I identify as asexual. I am on the board of directors for SMATI. For those of you who don't know what SMATI is, it stands for the Stanford Medicine Alliance for Disability, Inclusion, and Equity. And I published an article about my experiences and the barriers that medical students in general face when they navigate the wards in particular. And so I can talk about what it's like to disclose one's disability for political purposes. I also got involved in this program for similar reasons that Dr. Sutha did. I remember what it was like becoming ill during training and not really knowing disability culture, thinking I was the only one, and wondering if I should leave and being told to my face that I should leave. And I remember what it was like afterwards. It was a night and day difference when I met Dr. Poullos and he told me that another thing was possible. He told me about the existence of SMAC, and I got access to a community of people. And I thought it would be great if that kind of a network could be established nationally. And so when Dr. Poullos approached me about starting a mentorship program, I was like, oh yes, we should definitely do this. There's a huge need for spaces like this. So that's that. So about my disabilities, I have a few different chronic illnesses. It's kind of a long list. But I guess to give you guys a picture, I have a connective tissue disorder and many comorbid conditions like chronic migraines, POTS, mast cell activation syndrome, and gastroparesis, to name a few of them. And I'm also an ambulatory wheelchair user. I had the experience of developing my chronic illnesses, or many of them, while in training, and had to seek and implement accommodations on the wards without a diagnosis. So please do feel free to ask me anything related to what I've mentioned so far, but I'm also happy to answer questions about the considerations about publicly disclosing your disability for political purposes, disclosure and seeking accommodations when your disability is actively evolving or without a diagnosis, or if you happen to be a shy person. Also, feel free to ask me about developing a disability during training, leaves of absence, disability insurance through your institution, not necessarily nationally. I don't know much about the national kind of SSDI, but I do know a lot about getting disability insurance through a school. Ideas on how to shift the needle for disability inclusion at your institution, especially if you're further down on the ladder of training, and the interplay between one's disability and other identities. And you're also welcome to ask me about anything else, with the caveat being that I might not be as familiar with the topics, but I'll do my best.
So yeah, my name is Pete Poullos. I'm an abdominal radiologist at Stanford. I was a GI fellow at UC San Francisco in 2003 in my first year when I had a spinal cord injury and got paralyzed from the neck down. I decided to retrain in radiology not long after that and started my radiology residency at Stanford in 2004. Finished my training in 2009, and I've been on the faculty ever since. My disability is mostly around mobility, but also problems with circulation, and I've had hospitalizations for a few different things, wound infections, drug overdoses / sepsis. Still haven't figured out which one that was. Probably sepsis, but there may have been a drug overdose at the same time. And I had ICU psychosis the last time I was in the hospital, which really sucked. And you know, I've been mostly well accommodated. I remember my program director in GI coming to me in the ICU and saying, we'll do whatever we can to get you back to work. At Stanford, they were like, you know, pretty accommodating, although I was like very careful not to ask for too much. And I did have to figure out a lot of my own solutions to things. Most significantly, this volunteer program that I have where undergraduate students shadow me and provide me personal assistance at the same time, which gets around all manner of inaccessibility and makes me way more efficient. If you can find a human being that will do that for you, or a set of them, I think that's really helpful. So it wasn't until I founded SMATI in 2018 that I realized that things at Stanford were also pretty bad. I saw a comment in the chat like, did this happen to you at Stanford? Suchi answers yes, Stanford. And I wanted to say like, we're not that great. Like we have a lot going on. SMATI is doing a lot there, but it's like one layer down. You do not have to pick up very many rugs to see the dirt on the floor. So don't be too impressed. That's for sure. Let's see what else. So I just I thought that, you know, seeing the benefit that Suchi had and some other people had from mentorship, and realizing that like it couldn't fall on just a few people to provide this kind of mentorship, that we needed to like create a network of people to mutually mentor each other. Of course, it sounds like this was the way it was planned all along. There were a lot of twists and turns and decisions made and mistakes made along the way, but I'm pretty happy that we have created this community, and I'm just super proud that that you guys choose to spend one night per month with us and with each other, like talking about disability. And I don't know, I can answer a lot of questions about disability. I don't really have a specific area of interest. I'll just chime in with whatever you give me. So that's all for me.
I'll start off with something that people submitted and in the form, and I'll also put it in the chat. This is probably one that a whole bunch of people are thinking about. How much information is safe to disclose while applying for jobs, residency, fellowship, attending positions, and programs that have not personally met you yet, particularly early in your career? Is it okay to withhold disability-related information until an offer is being made? Who should you contact while applying for jobs for disability-related accommodations? So obviously, you're only bringing your own experiences and knowledge, and you're not legal experts and everything. So with those caveats, what do you have to say in response to these questions that you've all navigated, or at least have thought about navigating in the future, given your pretty varied disability experiences?
This is such a tough question. We could talk about this one for hours, and we do. I think it's a highly personal question also, depending on where you are in your training. More risk the younger or the earlier you are, more risky depending on what kind of disability you have, certain ones being more stigmatizing than others, especially like mental health or things that are like considered psychosomatic in some circles. I say that, and that if you can use it, if it benefits you in some way to disclose, then I would consider disclosing. For me, when I was applying, there wasn't a choice. I mean, I didn't have to include anything about my disability in my application, but it would have been silly for me to show up to interviews in a wheelchair to programs that and like surprise them. But, you know, knowing that some of them would rather not have like a resident in a wheelchair. And so I wanted to screen out those programs. And so I just disclosed in my application, only wanting to, but you know, again, this is after medical school and after already completing a residency. And so, I mean, and I had a backup plan, being that GI was still there for me, no matter if I got a radiology residency or not. But you run the risk not disclosing and getting offered a position and then disclosing afterwards of like blowing up your future at that institution, because I think that really upsets people. That upsets people more than just about anything, like what they see as this dishonesty up front. And it can like damage a lot of trust. So that's my first little tiny stab at that.
That said, that it is 100% your legal right to do that, to not disclose, and to once you have the position secured and they've given you the offer, to then ask for the accommodations. The argument, as Dr. Poullos made, can be made as well, that just early disclosure is advantageous, because it, number one, lets you know what the environment like is there. You can kind of get a sense for if it will be a welcoming environment for you. Though, like, you could go somewhere legally that they would have to take you. By disclosing early, you get a sense of where may not have the appropriate infrastructure or support structures that are there to help you work as best as you can. At our first Disability and Healthcare Conference, we had a talk from Nicole Taylor from Wake Forest, who talked a lot about early disclosure as a tool for really being able to like assess and kind of really make sure that you go into the situation with like eyes wide open about what resources will be available to you and the advantages of that. But as Dr. Poullos mentioned, that works well for people with disabilities that might be more understandable to the institution, or as Neera Jane calls, legible to people. That is like disabilities that people can understand more clearly. When it's something that might still be a little bit more nebulous or highly stigmatized, like Dr. Poullos mentioned, mental health conditions, less clearly defined conditions as well. There can definitely be many opportunities where that may backfire. For me personally, I disclosed in all of my applications, especially since I was going into a field where my personal experience directly impacted kind of my my direct path into it. It's not something that I necessarily had to, because it would fall under the category of a non-apparent or invisible disability, potentially something that I could have not talked about. But I felt that it was very central to my motivations and the things that I wanted to do within the field. And so I did talk about that. That said, it was a lot easier to talk about my medical journey as like something that I overcame, or something that was in the past, as like a source of strength, and not necessarily the ongoing struggles that were part of my day-to-day life at that time. Particularly when applying to fellowship, I knew that transplant or dialysis were on the horizon for me again. And so I did eventually disclose to my top programs to say, you know, this is where I am. This is what I'll have to deal with likely during my fellowship time with you. So that I could enter the situation with eyes wide open to know what they would be able to do to help me perform as best as I could.
Before you answer, Suchi, I just want to say, like, Ken and I both understand the power of inspiration porn, like using your story of like overcoming or rising above. I was paralyzed from the neck down and now I can walk. Who doesn't love that kind of a story? Sorry, go ahead, Suchi.
Yeah, no problem. I think that was a good point. I think I won't talk about the things that you've both already brought up, but one thing I would like to chew on a little bit more is in favor of not disclosing, or like arguments that I've thought about in light of that. So for those who do have invisible illnesses, I've heard from others that one approach some have taken is to not disclose on one's application or telling a program director or anything like that, but instead reaching out to whoever is in charge of disability accommodations once they've gotten admitted. And for some disabilities, that can work well, because those who have accommodations might kind of fly under the radar of the program. And I've heard people doing that and having it work well for them. However, in my case personally, I don't think that would work as well. I think something, I haven't gone through the experience of applying with my disability at least being known to me. But if I do apply for residency in the future, something I would think about doing is maybe calling every disability services office or HR department of every program that I'm considering or really like, and sussing out in advance, what the climate is at the institution, and then kind of thinking strategically about whether or not to disclose. But that would also depend on my state of chronic illness at the time. So for instance, right now, my illness is very apparent. I need my wheelchair to leave the house, and you can't hide that. And even without it, I'm not, I have a certain progression of disease to the point where I need a caregiver to do to help me with many activities of daily living. And that's something that I really can't hide from any program I'm considering. I'm, for instance, thinking about away rotations. I think I'm probably going to have to tell program directors at whatever away rotations I go to. So in my instance, just because the extent of disease is large enough, even if you wouldn't know by looking at me, I still think that it would be in my best interests to disclose. But, for those who can sort of pass, it might be okay to do that. And that's something I would do if I didn't have as many of the what you would call so-called limitations. So, yeah.
You could be making a lot of phone calls to HR and disability service providers, but the only person that really matters is your program director.
That's true.
If you have them on your side, there's or not, that's kind of what makes or breaks you as a resident.
Well, thanks, panelists, so much. And so my name, for everyone who don't know me, my name is Joe Kim. I'll be helping to facilitate some of this discussion. So we got another question, and this one is regarding residency. What kind of biases did you face in the process of going through residency? This person says, I'm still in preclinical training, had to go through many hoops to get accommodations, simply because many people at my institution were unaware of the ADA. So regarding residency and even fellowship, we can talk about that. So perhaps we can hear from Ken, then from Pete.
Yeah, I have less formal experience with this. I did not formally pursue accommodations, not because I wouldn't have benefited from them, but because I didn't know that that was a thing that I could do. I think similarly to many people's experiences, when like I would talk about things with people, nobody ever really explained to me what was possible to me in terms of accommodations. I had heard about accommodations in terms of like mobility things and other those sorts of things. I had worked with another resident that had an ASL interpreter that followed them around. But I had never thought about what it would look like to have schedule accommodations or other kinds of things for even like accommodating the need that I have to be on dialysis at night. So I just worked it out myself that I would just do manual dialysis and come to the hospital, which kind of looking back on it was probably not the best thing to do. Yeah. But I think what part of the things that we've been trying to do in normalizing discussions about disability is making sure that people know that there are people with disabilities in the field, and normalizing the process of asking for accommodations by normalizing the way that we offer accommodations to everybody, instead of like singling out people and being like, do you need accommodation? Just in general orientations, just saying anybody who needs accommodation, these are examples of things that one could ask for, and then normalizing it so that it's a more easy thing that people know that is available to them. But I think a lot of this this kind of stems out of lack of knowledge on administrators' parts, on program directors' parts, HR professionals' parts, etc.
I mean, I ran into biases, I think, kind of all through the process. You know, my interview at one place, the very thoughtful program director was just talking to himself. Let me just picture what the residents look like on call. Oh yeah, they're running here, they're running there, they're hanging films there. Oh yeah, no, I don't see how you could do this residency. It's like, why did you invite me? Why didn't you have this conversation with yourself beforehand? And why did you invite me to this interview? You know, he thought he was being helpful, but I mean, he was really just being discouraging. And, you know, in asking for accommodations, I really didn't know what was possible. I was lucky that I had a program director that sort of knew her latitude and wiggle room in radiology and what was required and what wasn't required. So I think that's important for you to educate yourself on in terms of like the ACGME milestones and exactly what is like required versus like desirable or useful in the course of a residency. I got singled out sometimes in lectures by never mind, he was sort of a weird guy, but you know, people would often like talk about me as if I wasn't there, like as a discussion point, as like, well, if Pete can do it, why can't you do it, sort of a thing, which is a really uncomfortable position to be in. The GME office still is not wheelchair accessible, so I could never go up there, and I still can't go up there. And I would say that it just, now talking to other people, seems like it's almost random who gets accommodated and who doesn't. It's just very local. Like, it doesn't even matter how on board the leadership is at a particular institution. If a program director or someone screening your application even isn't on board, you can get shut down and not really know why. So I think it's really important to play to your strengths and emphasize, what you can do and downplay what you can't do. It's a weird balance, right? Because we're like trying to portray ourselves as strong at the same time we're asking for things. And so that balance is really hard to strike, but it's worth trying to strike it.
There seems to be kind of a set of questions revolving around how to navigate issues with HR, or maybe going to HR with issues, both. So bad responses from HR, but also bad responses from other people, and needing to maybe invoke HR, human resources. So for instance, what would you do if HR denies helping out with some kind of decision regarding employment? And then similarly, I think there's kind of a question of at what point do you escalate things, or how would you escalate things if you're told to quit, or not given any kind of flexibility on other really sort of critical points that might be more obvious to you all than to me, since you've lived them.
Sorry, what's the question?
Okay, I will restate the question in a different way.
I don't know. Somebody go ahead and answer it.
Revolving around HR, at what point would you go to HR? When is that appropriate, and how would you approach that process? And then if you have a problem with HR, they're not helpful when you have some kind of dispute or issue around employment, how do you then proceed? Is that clicking a little more?
You're better off finding your own answers and bringing them to HR than like asking HR for the answers. You're just so much better off being like, you're all experts on your own disability. Like, find a network, figure out what works for you, and then tell them what you need and want. And if you can just broker that directly with your program director, or like you're speaking of like, being a resident or an attending, since we're talking about HR, I think you're better off. Like, people love to have the legwork done for them. If you can present your accommodations on a platter, I think that's more appealing than like, just saying that you need help. And going to HR, while it's, within your right as a first step, I feel like I would go to HR more if my department were being uncooperative. And then if HR couldn't find a way to make them comply, then I might have to start escalating from there. And that could look like a number of different things. It could be making threats, filing grievances, or going to an ombudsman if you're at a university. It could be contacting a lawyer. Making perfectly clear that your desire is not to sue, but that it's also clear that your rights are being infringed. but I think that's more of like I wouldn't say last choice, but because it shouldn't be a last choice, because things can deteriorate even further before you get to the point of a lawyer, and then it's too late. So you kind of have to know the timing on that.
Yeah, again, less from personal experience with HR myself versus what I've learned from seeing barriers that our residents have that have come to us with problems that they've had with HR. Our HR, and unfortunately, I think this may be true of many HRs, are often uneducated about what the roles of residents are. They focus much more on like the hospital employees, like the nurses and other staff. The fact that residents particularly may work across multiple different teaching hospitals also complicates things, because they may have to deal with HR across multiple different institutions within their same training program. So for us, we've often seen that our residents that are having difficulty is because they are trying to coordinate things between GME and HRs at different locations, and it can be difficult to get them to kind of coordinate and talk to each other. Again, I don't have a clear solution of how to fix that, other than what Dr. Poullos mentioned of trying to work locally. I was fortunate and privileged to work with people that kind of understood my situation and were able to help implement situations that worked for me just in my day-to-day working that weren't formal accommodations. But again, I think there are many instances where seeking formal accommodations is an advantageous route to take in protecting yourself and formalizing things. Where if things happen to not go right, or if there are problems with your individual program. I wish that there were a better, clearer answer to this, but I don't have it.
If you wouldn't mind me sort of chiming in, I don't have any experience with HR, but I can broaden the question to maybe rephrase it and say, what do you do when you're told no by somebody in authority? And I only have experience with that at the undergraduate medical education level, but I think some of those lessons could be generalized to later stages of training too. I would say the first step is to not panic and to say, just because this person told me no, it doesn't mean the answer can't be changed to yes later. And all it takes is creatively thinking about how to get that to happen. And sometimes it does feel like you're doing some gymnastics to get that to happen, but it can happen. So I think the way that I've had people change their answers from no to yes was finding an ally somewhere within your institution or even outside your institution, and joining this program is actually a great first step, because you know there are others like you. It gives you the courage to say, no, it's not just me making a scene or something. It's worth fighting for this. And it also gives you a sounding board. And then the second step is to talk to as many allies as you can about what to do moving forward. And ideally, find somebody who is an ally who would be willing to vouch for you, ideally within your institution, but sometimes even faculty at other institutions who are behind you can talk to the faculty at your institution. They might be high enough up where, you know, like at a certain point, the faculty kind of do all know each other, even if they're at different institutions. They may have trained together. They might be part of a similar administrative network. So that can go in your favor. Also, presenting the information in a different way can sometimes change people's tactics. So, or their response to you. So for instance, at our institution at Stanford, there is a mistreatment reporting committee and an Office of Medical Student Wellness. And when medical students encounter abuse on the wards or discrimination on the wards, they go to this Office of Medical Student Wellness and report mistreatment. I went to the head of this committee and explained to her in person what was going on my training. And she was like, yeah, we can't really do anything about it. Sorry, you're on your own. And then I was encouraged to submit my complaints in writing. And so I wrote kind of a long narrative of what my experience on one particular rotation was like, and said, you know, you don't have a category for mistreatment in this way. All your mistreatment categories are like for sex and gender-based offenses or race-based offenses, but this felt like mistreatment to me, and here it is. And the same person read the statement and was like, oh my gosh, this is horrible. And you've presented some clear, you know, first steps that we could do to address this. And then a task force was created to change the culture within the medical school. It was the same person. So sometimes it just takes, you know, trying again through a different route, and talking to as many people as you can within your institution. People talk organically behind the scenes. And if you're respectful about the way you go about this, sometimes things can work. I recognize that my experience is one of privilege too. I am at an institution where things go horribly wrong a lot of the time, but there are enough people there who believe in anti-ableism that my complaints had traction. But, and still recognizing that, I just wanted to share that experience to say, like, you know, I don't have HR experience, but I can say that some perseverance and letting go of one's own shame around being a squeaky wheel can help serve you.
Yeah, sometimes people need time to digest these concepts if they're not familiar with them. And I'd say it's like categories of natural allies, but diversity people, in my experience, have been sort of like the closest allies. They come closest to getting it amongst people who are not actually in the disability space. So maybe find someone that's just keep knocking on doors until you find one that'll go to bat for you.
Thanks, panelists. So the next question is kind of a blend of a few questions we've been getting, both submitted earlier as well as coming in through the chats. And it refers to mental health, mental impairment, emotional health, emotional impairment, even leading to things like physician suicide. And just the question really is focused on if it's really our brains that where we're just the disability affects our brains, our thinking, our problem-solving abilities, and perhaps it doesn't allow the person to really effectively manage and direct patient care or treat patients, then what can they do? You know, are there other ways perhaps that they can work, but either reduce that stress, or maybe it's not even an issue of stress and workload, perhaps it's a different problem altogether. So the question really is more just around if someone has that level of mental or emotional impairment that they're not able to function, what suggestions, advice, what kinds of things do you think you can say to that person to encourage as well as to help them on a practical level?
Boy, that's tough. You know, I talked to a doctor who confided in somebody that she was having, well, the background is that she had a complaint, like a complaint filed against her that she did something that was incompetent. And she went to talk to who she thought was a friend about it and confided that she actually had cancer and was undergoing chemotherapy. And so then her friend looked up the kind of chemotherapy that she was on and to see if it had any cognitive effects. And then she found out that it did. And this led to like this person getting being sent to neuropsych testing, doing well on all but one category, but they really seized on that one category as like proof that her chemo was causing cognitive impairment, and they used it to like push her out. And so I think that it's like a super fine line. I think that nobody has a right to know, you know, your specific diagnosis or the specific drugs that you're on. Say you would hopefully, you know, you have enough insight as a person to know whether or not the meds that you're taking or the illness that you have is causing you to be cognitively impaired to the point of not being able to practice. I mean, we all kind of are judging that of ourselves all the time anyway. Like, am I reading them enough? Am I current in the literature? Do I know all the recent guidelines? Am I sober enough now that my last drink was 5 hours ago or whatever? I mean, you make, like, everyone makes those kind of calculations. So, you know, your first duty is to your patient. And then just trying to like set up your life and working with a physician to set it up to like maximize your capabilities would be well, your first duty is to yourself in your life, but in your job, your first duty is to your patient.
Yeah, this is a tough one. There's, as Dr. Poullos mentioned, there's a certain amount of self-reflection that we all have to take in entering the medical field, and humility in recognizing what our limitations or boundaries may be, but at the same time, that's not to say that those boundaries should be imposed upon us by other people. Again, I don't profess to know the answer to how to address this, but I think that honest and frank discussions with yourself, with your medical team as well, to kind of think about if you have a medical team that you trust that has a good understanding about you and what you can do with and without accommodations, I think is a useful starting point.
I guess something else to think about for this question, and I'm not sure if I'm misunderstanding, please correct me, Dr. Kim or Zoey, but when it says if someone isn't necessarily able to function in a hospital or clinical environment, I'm sort of wondering, are the people who are asking these questions thinking about continuing to practice in clinical settings in spite of this, or are they thinking about pivoting and doing something that would require an MD but sort of removes them from these environments? I'm not sure. So that's sort of one thing to think about. There are ways to practice medicine where you're outside of the triggering environment that would be associated with training or being a hospitalist. And so that's definitely a possibility, but it would require kind of getting through the training and then making it on the other side, or maybe adjusting the way, the pace of training, or, so I guess I'm kind of trying to think creatively about it. But the second thing is, I'm wondering what the extent of the mental health and emotional health concerns, like to what extent is it causing that feeling of not being able to function in the hospital. Because it is all on a scale. There is somebody very close to me who has a few overlapping mental health conditions and struggles a lot with those mental health conditions on the wards. But this person is still an excellent physician and actually has gotten some recognition from the higher people up at the hospital where this person works because of that level of excellence. But it has involved this person being open with their program director about their particular accommodations needs and struggles, their need for therapy on a weekly basis, and debriefing with their team if something on the wards triggers them. And it's happened where like there are situations that reminds this person of trauma they've had in the past and have been triggering. And they've been able to debrief with the team and say like, hey, this was hard. And so the team would, make accommodations and say, you have permission, for example, to leave the room if you're triggered and come back later, or you have permission to not interact with one particular patient and patient family if that family has triggered you. So there are ways to go about things, but it kind of just depends on where the person who is asking these questions kind of sits on that spectrum of feeling completely unable to practice in the clinic, or maybe partially unable in certain situations. But I do think it doesn't have to be sort of an all or nothing decision. Of course, you do, as Dr. Poullos and Dr. Sutha already mentioned, you do have to look back on yourself and think at what point could I be doing a disservice to the patient? And as long, it's unfair that we have to think about it more than others. I think if ableism wasn't a thing, we would be thinking about it the same amount as others. But it's important. It's an important question to be thinking about. At what point am I doing a disservice to patients? And if the answer is I'm doing a disservice to patients, then it's time to step away, I think.
I would say that it's like the overwhelming minuscule minority of people with disabilities that are any danger to our patients.
Yeah.
To emphasize that point.
And thinking of creative ways to get around these things, that's not doing a disservice to patients. Just because medicine is practiced differently by people who have mental health conditions or any other condition, it doesn't make it worse for the patient. It's just different. So.
I mean, people make these sorts of compromises all the time. Like, yeah, I want to be a good surgeon, but I don't want to kill myself. So I'm going to go to the University of Hawaii's general surgery program. I mean, I'm just making that up. I have no idea what their surgery program is like, but or I'm going to do my residency at Kaiser and not at MGH. I want a community program, not an academic program. Part of the reason I work in academics is because despite the fact that I really want to make more money, I don't think that my body could keep up with the private practice workflow. So I compromise. Turns out it worked out. I like my job, but a lot of where I work has to do with my physical disabilities.
Well, thank you, panelists, for tackling that difficult problem or question and problem. And I know that there's in the chat here some discussion about maybe in a future meeting discussing some options outside of clinical medicine. So we can certainly circle back on that. I'll pass it over to Zoey now.
Hey, all right, I'm going to put a question in the chat. As I'm doing that, Dr. Sutha, did you have anything you wanted to add to that conversation that they were just having? No, cool. All right, great. So this one revolves around accommodations in residency, but I think folks could speak to outside of residency also. It's a series of questions and I'll read them. what are the options for seeking accommodations in residency? What should programs respond to? What should the resident be prepared for? So kind of responsibilities on both sides. How do you come prepared for requesting accommodations and negotiating all of that? And then do you have any tips on, anticipating developing needs over time throughout training? How might you then identify accommodations when no one has experience with the particular barrier that you're facing or with your particular types of needs? And what then happens if a program rejects your request for accommodation?
Okay,
Or
this is turning into a 10-part question, Zoe.
I know, but these are all related. And it's a story, right? It's like the arc of accommodation over residency. And then if you get approved, how do you handle the fact that the burden often falls on co-residents? It's also in the chat, you can read it.
Is this, oh, this is, okay, it's in the chat. There we go. I've tried to stay away from the chat because I want to remain focused.
Yes,
But
that's
here
very
it is. But since, okay.
Since I wrote a novel.
You know, I had the benefit of doing my rehab, and this is something that comes along with, like, you know, having like a sudden traumatic interruption in your life. Like, it started with a hospitalization, not with a series of like clinic visits, you know, which is the way a lot of people's disabilities are diagnosed. But I was at a county hospital, and a lot of people there were low resource, and there was a lot of information given about government programs, and I took advantage of the California Department of Rehab, and they assigned me a rehab technologist who came to my house and looked at my physical functions and made a bunch of recommendations, and actually came to my work site and like took a look at it and helped implement what he thought were like the best ergonomic and physical and voice recognition approach, and the state like also paid for it. So it's kind of like a win-win. I brought in my guy, it sounded really cool. Oh, I work with a rehabilitation technologist. It showed that I did my homework like ahead of time. I gave them the answer. I mean, he was a serious expert. And so I thought that, so if there are government programs, I think in your state, I don't know how that breaks down by politics, or even if it does, I don't think disability is like a typical red-blue divide. I think that disability is a little bit more complex on its political breakdown. After all, like, you know, the ADA was signed by George H.W. and his son signed the ADA Amendments Act in 2008. And so, you know, so, I mean, the issue of like what's reasonable, well, you all know about what's reasonable there, if it's like not an undue burden on the institution and doesn't fundamentally alter the job itself or the study. So, you know, I think that the institution has a wide berth, unfortunately, according to the law, to determine like what constitutes like their standard. Like, for example, in technical standards, they just have to be prepared to justify why, and in most cases, like they can justify it. So, I mean, to anticipate the needs, I think it helps to talk to a lot of people. I get emails all the time about people with disabilities wanting to be connected with other people with disabilities, and I try to make that connection. If the program rejects your request for accommodations, I mean, I think our previous advice still holds true, and finding other allies, going up and down the chain of command, trying to find people of influence to go to bat for you. And when it falls on your co-residents, that's tough. You know, I did not do night float, so my co-residents had to do more night float on that because of that, but they kind of understood why I couldn't do it. And there was, and I was also on call with them like every Wednesday from 5 p.m. to 10 p.m. So it was like everyone had like one night during their night float where they didn't have to start until later, and they could like sleep in and just relax. And so they chose to see that kind of as more of a benefit than a drawback. But you know, that also, you know, it's radiology and not general surgery, and we're talking about like, you know, a few days and not, I mean, there's a big difference making people go Q3 instead of Q4. And so programs that have small residencies or small cohorts are probably not the place where you're going to get the most support. Big programs at big institutions are probably a better place where they have the manpower to support that when it's a schedule issue. That's all.
Yeah, though I didn't seek like formal accommodations when I was interviewing for programs, I asked questions about like Jeopardy systems, kind of cover systems for when people were out sick. I asked about like maternity leave, what their policies were, and how they handled when residents were out for other different kinds of other reasons that more common reasons that residents might be out of the rotation of working. And I intentionally chose a larger program where there were, particularly for residency, where there was redundancy and other people that would be able to take those roles. And it was built into the system that there were people who had that role of filling in when people were out. That became harder when I was in fellowship, where, again, I picked one of the larger pediatric nephrology programs, but that was only 2 people in my cohort. And so I was fortunate that my co-fellow was very understanding when they had to step in and cover for me because I was out for whatever reason. I did hear through the grapevine, nobody ever said this to my face, but I did hear one of the other co-fellows had, like one of the senior co-fellows had said something, had made a comment about like, why did we accept somebody who we knew may have to take time off when that is going to be more burden of time working, of us having to work. Again, I was fortunate that the people that I worked most directly with did not, at least openly to my face, did not have that attitude. And I was fortunate that I demonstrated that I was able to work and be of value to the program in the insights and the perspective that I brought.
All right, so I'm going to wrap up with a question that I think is super important and I actually think about a lot. I'm just directly quoting this in the chat, but how do we advocate for more CRIP representation in healthcare without drawing comparisons to gender and race, equality movements that smack of whataboutism? In January 2022, AAMC reported a 21% increase in the number of matriculated Black first-year medical students just between 2020 and 2021. But they're still recognizing that there's a big gap in disabled students in terms of representation. Now I'm paraphrasing. So what does it look like to similarly advocate for healthcare providers with lived experience of disability while avoiding this kind of like, what about us? And I would just add, to me, the sort of complement of this question is, how do you think about collaboration? Because there's a lot of other kinds of forms of exclusion and accommodation that I think can be really productive in thinking about next to disability. So even something like people who are pregnant in residency or during some other stage of training, or who face other kinds of conscious and unconscious bias, basically.
You should read the Sin's Invalid book, Skin, Teeth and Bone, Skin, Tooth and Bone. I can't remember if it's teeth or tooth. Anyways, it's very easy read. They talk about 10 principles of disability justice. And I think that adhering to those principles it's like a good roadmap for how you should behave. And like one of the big things is cross movement organizing, that nobody is oppressed in a vacuum, that an oppression, I can just butcher the Martin Luther King quote now. It's like, what is it? An oppressed person everywhere is
Injustice. I think it was
Yes.
injustice.
Yes, that one. Go ahead. Can you say it in its entirety?
It's like
No?
something about injustice, something everywhere, something.
Injustice
something.
anywhere is a threat to justice everywhere. Anyways, it means basically that, because of issues of intersectionality and how the system of racism and ableism works, that we should basically be supporting all other groups, and we should expect that they support us also. I don't think it's whataboutism to like point at gains that other groups have made and pointing out that we haven't made the same gains. There are reasons we haven't, like implicit bias against LGBTQ and Black people has steadily declined over the last 20 years. And while explicit bias against people with disabilities has decreased, implicit bias hasn't budged. We have to ask ourselves why that is. And so, I would say, so that there's that in the cross movement solidarity, and then there's cross disability organizing too, which is to always remember to include everyone in your disability activism. That's super important. And there are 8 other principles to which you should adhere. But I think that we have a lot to learn from the Black and LGBTQ movements. And why shouldn't we utilize similar techniques or draw analogies or parallels when it benefits us?
I also don't think what about is bad. To say what about us is to point out, as you said, how injustice can be replicated in many different contexts. And to say what about is kind of painting an analogy that isn't a bad thing.
Yeah, and I think also as was mentioned, acknowledging the perspectives of people, multiply marginalized people that are existing at the intersections of these different identities, and recognizing history as well, the ways that these different movements have been tied in the past, the Black Panther movement and disability rights movement, the thinking also the way that Asian American protesters and justice movements have partnered with the Black Panthers, et cetera, kind of the ways that these different movements have intersected. I think learning from the ways that those things have been able to partner in the past is important.
There's so many other good questions, and thank you to everybody who submitted. Maybe we can do this again in some form, and we'll definitely pay attention to what people said as inspiration for further topics. So we really appreciate the work you put into thinking those up and kind of crafting them. At this point, we are 1 minute from the ending time of the program. So I'll just thank all the panelists for all their time and energy at the end of a long day.
I realize you didn't ask me for a parting word, but I'm going to provide one.
You may all give a parting word if you would like it.
Parting word number one, you can do it. That there's no reason why you can't do it. Other people have done it. We will help you. We will try to help you figure it out. But ultimately, you will be the person to figure it out and move forward. Like, you need to trust yourself and have faith that it'll work out. It may not work out immediately, but it'll work out. And my second thing is really do explore relationships with intersectional groups. I think that like a lot can be learned from bringing people in who sit at the intersections and have credibility in both worlds, and that can change minds. And there's a lot of money in diversity. So why shouldn't some of that money flow to disability?
Yeah, I just appreciate everybody being here and listening to us. Again, we don't have all the answers. We continue to learn from all of you as well. But yeah, we're all in this together.
Yeah, well, thank you all for coming. It's really cool to see this community and how it's grown over the last couple of years. My parting word is connect to each other. This group exists, but it was sort of intended as a jumping off point. So you now all are in contact with each other. Something that's brought my career to the next level is having one-on-one conversations with people. We would have loved to pair you guys, mentor mentees, but we just didn't have the bandwidth to do that. But you all have a space to get to know each other, and you can private message and share contact information and Discord message each other. Please take advantage of that. It really, really helps to talk to multiple somebodies one-on-one to get multiple perspectives in kind of a less crammed setting than even this one. So that's it from me.